gives us great pleasure to introduce Nico Marx, another world expert from the University of Aachen, who's going to make a case for SGLT2 inhibition. Nico, this is becoming your home, I think.
Yes.
You've been here many times.
Thanks, Derek, for re-inviting me. It's a great pleasure and a great honor to be here. But I have to admit, it's tough to do a pro-con discussion with Jens, who's kind of the pope in the GLP-1 field, but I'll do my best. This is my conflict of interest slide. I'm having interaction with various companies, but don't take any personal honoraria. So what I'm going to do, since I'm a cardiologist, to first talk about cardioprotection and then switch to renal protection. Jens, I come back to your slides and show the leader data. Everybody's aware of it. And Jens nicely and convincingly showed us the reduction of 3-point MACE by liraglutide compared to placebo. And he also mentioned the data on the single endpoints here, showing that everything goes into the right direction, CV death, MI, and stroke, suggesting that liraglutide reduces cardiovascular endpoints in patients with diabetes and high severe risk, most likely through a reduction of arteriosclerosis events. I think we are on the same side. The key question is, if in 2018 these arteriosclerosis-related events are the major problem in diabetes, or maybe we are missing the boat if we're only focusing on MI and stroke. And so I'd like to invite you to go back 20 years and look in patients with diabetes on the development of MI and stroke here. And this has been recently published, a very nice paper showing that over the last 20 years, there was a marked decrease in both myocardial infarction and stroke in patients with diabetes due to the fact that we implemented antiplatelet therapies, statins, ACE inhibitors, and certain coronary interventions. And this decrease has led, if you look at cardiovascular death, for example, data published last year, to a significant decrease in CV death in patients with diabetes. But if you compare this to non-diabetic subjects, you found a similar decrease. But if we solve the problem on MI and stroke, there remains an increased risk here for patients with diabetes. So there seems to be more to it. And this is, of course, heart failure. So heart failure in diabetes is a topic that these data are known for 15 years, but I think under-recognized by cardiologists as well as diabetologists here. These data are published in 2004 showing no matter how old a subject is, if he is suffering from diabetes, his risk to develop heart failure is markedly increased to non-diabetic subjects, compared to non-diabetic subjects. What about the prognosis here? This is non-diabetic subjects, patients with diabetes, all heart failure patients, and you can see here a patient with diabetes and heart failure has a likelihood of 55% to die over the next 3 years, so it has a high mortality. This is data from 15 years ago, and I'm talking about 2018 data. So is heart failure today still a problem? This is data published in The Lancet 2 or 3 years ago, looking at the initial presentation of patients with diabetes with different manifestations of cardiovascular disease. And you can see here, one of the leading causes, the second leading cause here is heart failure, even more prominent compared to non-diabetic subjects. What about the prognosis of heart failure in diabetes today? And this is data from the PARADIGM-HF study. You may recall this is the study that tested sacubitril valsartan versus placebo in heart failure patients. And here is shown cardiovascular death comparing non-diabetic subjects with the normal HbA1c compared to patients with diabetes or undiagnosed diabetes. And you can see there's a marked increase in mortality here with, over the follow-up of 2.5 years, an overall mortality of 21%, meaning that 1 in 5 patients with diabetes and heart failure dies over this period of time. So having shown you this data, I think everybody can agree that heart failure with recurrent hospitalization and a high risk for CV death and total mortality is the leading problem in type 2 diabetes in 2018. I hope that everybody's on board. So let's look at the leader data that Jens mentioned already and the effect on heart failure hospitalization. And I don't see a significant effect. There's a non-significant trend, but certainly no effect of liraglutide, so the GLP-1 analog, on heart failure. But this is totally different if we shift gears and look at SGLT2 inhibitors with various effects on glucose, urinary excretion, hemodynamic, and potential metabolic effects. You're aware of the two large outcome trials here, EMPA-REG outcome and CANVAS. Both trials with SGLT2 inhibitors showed a significant reduction of the 3-point MACE here. And surprisingly, in EMPA-REG outcome, we saw this decrease in hospitalization for heart failure by empagliflozin with a very early separation of the curves here. This was significant already after 17 days, so a very rapid effect here. That was not only true for empagliflozin, it's also true in CANVAS here. Canagliflozin compared to placebo also showed a significant reduction of heart failure hospitalization with a similarly very early separation of the curves here. So these data suggest that SGLT2 inhibitors, in contrast to GLP-1 analogs, reduce cardiovascular endpoints most likely through a reduction of heart failure-related events. So let's look at this in more detail. In heart failure trials, the key endpoints are CV death and heart failure hospitalization. If you look at these endpoints here in EMPA-REG outcome, you can see, again, very early separation of the curves here and a significant effect in favor of the SGLT2 inhibitor. If you separate these two and look at the time course for CV death and heart failure hospitalization, you can see here that the effect on CV death was started early on, and there was a further separation of the curves here throughout the whole trial. In a similar way, this is true for heart failure hospitalization. Again, very early separation of the curves, but if you look at the hazard ratio, continuous separation of the curves here. The question is this true for everybody or only for patients with or without heart failure? And you may know that 10% of the patients in EMPA-REG outcome had heart failure at baseline here, and this has nicely been examined by Fitchett and colleagues here, and they could show that everything is on the right side here. So if you look at patients, heart failure at baseline, no or yes with respect to heart failure hospitalization, CV death. Of course, this is a small group only, but everything goes into the right direction, suggesting that this reduction in heart failure-associated events holds true in patients with or without heart failure. Let's look at another high-risk population. This is patients with CKD. We've heard that patients with diabetes and CKD have a tremendously increased risk for cardiovascular events here. And again, published by Christoph Wanner just recently, empagliflozin significantly reduced both CV death and all-cause mortality in this group of patients with eGFR below 60 and or macroalbuminuria. And in a similar way, this was true for hospitalization for heart failure. So in summary, SGLT2 inhibitors reduce CV death and heart failure hospitalizations throughout the whole study period in patients with and without heart failure at baseline, as well as in subjects with cardiovascular disease. Let's shift, one slide more. So the heart failure data are so good that we are now having 3 upcoming trials that even enroll patients without diabetes to test whether SGLT2 inhibition is a concept to reduce cardiovascular events in patients with heart failure, both with preserved and reduced ejection fraction. DAPA-HF also only enrolls patients with reduced ejection fraction. So let's look at renal protection. Jens already showed you this slide, but on purpose, you didn't show any more slides here. So this is a combined endpoint, significant effect, 22% risk reduction for the combined renal endpoint. But if you look in more detail, this is the combined endpoint, which included macroalbuminuria, doubling of serum creatinine, or need for dialysis here. This was mainly driven by a reduction of new onset of macroalbuminuria. My nephrology friends tell me that this is important, but I'm a simple cardiologist, so I care about the question that my patients care about: do I need dialysis or not? And if you look at this here, there's no significant effect. Let's look at SGLT2 inhibition here. very robust, significant reduction also of the combined endpoint here in favor of empagliflozin. But if you look at the single endpoints here, again, you find a significant reduction of the progression to macroalbuminuria. You find a significant reduction of serum creatinine. And this is, I think, most important here. You find more than 50% significant reduction of the initiation of renal replacement therapy. And with respect to renal protection, I think this argues in favor of SGLT2 inhibition. So empagliflozin reduces renal endpoints, including the initiation of renal replacement therapy. So my summary, and I try to make a strong case for SGLT2 inhibition, is that heart failure with recurrent hospitalization and high severe risk for CV death and mortality is the leading problem in type 2 diabetes. SGLT2 inhibitors reduce CV death and hospitalizations throughout the whole trial. Empiric outcome in patients with or without heart failure and in the high-risk population of patients with CKD. And with respect to renal protection, empagliflozin reduces endpoints, including the need for dialysis in this patient. So I think that makes a very strong case for SGLT2 inhibition. Thank you for your attention.